conditions. The basal ganglia have a significant role in controlling voluntary movements. Therefore, any condition involving damage to the basal ganglia will manifest some type of abnormal movement, such as the ones we will cover in this PowerPoint: Parkinson's, progressive supranuclear palsy, Huntington's, and Wilson's. Parkinson's disease. Parkinson's disease is a gradual, progressive, neurodegenerative disease. And I want to stress gradual because some of the conditions we'll cover in this presentation have very similar signs and symptoms as Parkinson's, but the condition is more aggressive. The typical age of onset is around 60 years old. However, nearly every condition we will cover in this course that has an adult or an elderly age of onset can manifest earlier. The younger man in this photo is the actor Michael J. Fox. He was diagnosed with Parkinson's at age 29. If you watch the video, Faces of Parkinson's, you will see more people who were diagnosed much younger than 60. All statistics reported in this course are just the average. According to the National Institute of Health, Parkinson's affects approximately 3% of the population and is more common in men than women. I personally believe that number is higher just based on the number of chiropractic patients I had with this condition. Research is showing a 5 to 10% inheritance factor. However, nearly every condition we cover in this course that does not have a clear genetic sequence identified will have research showing 5 to 10% genetic association. So if I do not state there's a genetic association with a condition, you can safely assume that somewhere there is some research going on suggesting a 5 to 10% familial association. Parkinson's clinical triad. Parkinson's disease is primarily diagnosed by clinical findings, meaning there's no established lab exam that can definitely diagnose this condition. All diagnosis is done by observation and physical exam. The three main clinical signs associated with Parkinson's is resting tremor, muscle rigidity, and bradykinesia. As we go further into this PowerPoint, I will point out examples of what these signs look like in a Parkinson's patient. Parkinson's clinical diagnosis. In order for a healthcare professional to diagnose a patient with Parkinson's disease, the patient must exhibit at least two of the clinical triad signs mentioned in the previous slide, such as tremors, muscle rigidity, and bradykinesia. An anecdotal test of administering L-DOPA can also be used to further validate the diagnosis. L-DOPA is a precursor to dopamine production. Decreased levels of dopamine is associated with Parkinson's disease. The L-DOPA is able to pass through the blood-brain barrier where it will be picked up by dopaminergic neurons and rapidly converted into dopamine. This test is typically only useful if the patient is presenting with extremely strong resting tremors at the time of the injection. If the patient's tremors are due to decreased dopamine, the tremors will temporarily stop after the injection of L-DOPA. In fact, L-DOPA is the pharmaceutical treatment for Parkinson's patients. However, since other conditions could cause a decrease in dopamine, this test alone cannot diagnose Parkinson's. The patient must have the attendant clinical signs. A pharmaceutical treatment for a condition is not a diagnosis for that condition. As I mentioned previously, there's no definitive lab test to diagnose Parkinson's disease. Currently, all definitive diagnosis is done post-mortem with a 95% accuracy. I want to reiterate that Parkinson's disease progresses very slowly, and with advocates like Michael J. Fox, researching is finding a way to slow the progress even further and hopefully one day find a cure. Parkinson's tremors. The tremors associated with Parkinson's disease are resting tremors. Resting tremors occur just like you would think, when the body part shaking is at rest and goes away when the muscle of the shaking tremor are engaged or if the affected person is asleep. Sometimes the shaking can be so violent that it shakes in the entire body. Resting tremors are most noticeable in the hand or hands, but they can affect the arms and legs. Typically, the resting tremor in a Parkinson's patient is asymmetrical or unilateral, affecting only one side, but the tremor can progress to the other side, making the resting tremor bilateral. If this occurs, the side where the tremor initially began will shake harder than the other side. Sometimes resting tremors in Parkinson patients' hands will manifest as pill rolling. Pill rolling is when the tremor manifests as a constant rubbing of the thumb and index finger and the middle fingers. This pill rolling resting tremor is typically only seen in Parkinson patients. Parkinson's muscular rigidity can be so severe that it limits mobility or technically a person's range of motion. In advanced stages of Parkinson's, the muscle rigidity causes dystonia. Dystonia is more than muscle rigidity. The muscle spasms associated with dystonia is so severe it prevents movement, causes twisting of the affected joint, and can be very painful. The muscle rigidity associated with Parkinson's disease is responsible for the stooped posture associated with this condition, and in part for the classic Parkinsonian gait. Muscle rigidity can affect the vocal cords, causing hypophonia or very low voice volume. Muscle rigidity can also affect the muscles responsible for swallowing, causing dysphagia. A Parkinson's patient's muscle can get so stiff from the muscle rigidity that they can also resist passive range of motion. An orthopedic exam used to test passive range of motion is called cogwheel rigidity. To perform this exam, the clinician extends the patient's wrist as far as they can without eliciting pain. The clinician holds the patient's wrist in that position for about 10 seconds and then releases it. A normal finding would be that the patient's wrist will return to normal position in a smooth arc. In a patient with severe muscle rigidity, the patient's wrist will have a jerky, ratchet-like movement trying to return the wrist back to the neutral position, just like a cogwheel. Parkinson's bradykinesia is responsible for very slow, voluntary movement. It is distinguished from muscle rigidity in that the person can perform the desired motion, but it just takes a long time. Whereas in muscle rigidity, the spasm or tight muscles are preventing the movement. Examples of bradykinesia are when a Parkinson patient has difficulty getting out of the chair. It is also responsible in part for the classic Parkinsonian gait. One of the bradykinesia signs symptoms associated with Parkinson's is micrographia. With micrographia, the patient will start writing with their normal size script, but the bradykinesia will cause the script to get smaller and smaller and smaller to the point where it's no longer legible. Bradykinesia and muscle rigidity combined. Some of the signs and symptoms associated with Parkinson's are caused by a combination of muscle rigidity and bradykinesia. One example is the classic mask face associated with this condition. The masked face expression is a result of facial akinesia, literally no facial movement. When a Parkinson's patient has facial kinesia, they have to force a smile, and they lose the autonomic blinking function, which presents with a wide-eyed expression. The Parkinsonian gait, also known as the propulsive gait, is also a result of combined muscle rigidity and bradykinesia. The forward stoop posture and impaired balance is due to muscle rigidity, and the propulsive shuffling steps and loss of autonomic arm swing are attributed to the bradykinesia. Progression. Parkinson's disease is slow to progress, but it does present with a progressive pattern. Research has shown that this condition begins in the lower brainstem and migrates towards the cortex, stopping midway at the substantia nigra. At this point in the research, the damage to the brainstem is asymptomatic. Symptoms only become noticeable when the disease begins to affect the substantia nigra, manifesting in movement disorders. Eventually, if the patient lives long enough, the disease will reach the cerebral cortex, causing depression, emotional changes, and in 10 to 15% of the patients, it'll cause dementia. The dementia is attributed to widespread appearance of Lewy bodies in the cerebral cortex. The post-mortem evidence of Parkinson's disease. The two pathological features of Parkinson's disease is the presence of neuronal Lewy bodies and the loss of dopaminergic neurons from the substantia nigra. The presence of alpha-synuclein-containing Lewy bodies is the histological hallmark of Parkinson's disease. Postmortem specimens show Lewy bodies in the neurons in the brainstem, substantia nigra, and cerebral cortex. The pinkish-purple histology slide you see in the upper right side of the slide here features a cerebral cortex neuron with a black arrow pointing to the Lewy body surrounding the halo. The other significant loss is, for gross pathological finding, is the loss of dopaminergic neurons in the substantia nigra. The image in the lower right side of the slide shows a section of two substantia nigras. The Latin meaning for substantia nigra is literally black substance or substance black. It gets its name because dopaminergic neurons in this location appear black in a normal brain. And as you can see, the substantia nigra section on the right side of the image is of a healthy normal brain, and you can clearly see the dark line of dopaminergic neurons. The substantia nigra image on the left is from a person diagnosed with Parkinson's disease, and there are no dopaminergic neurons visible at all. What is progressive supranuclear palsy? Progressive supranuclear palsy is a rare, extremely progressive neurodegenerative disease. The age of onset is 50 to 60 years old, which is about the same time frame as Parkinson's. However, as with many conditions, it can manifest earlier. The symptoms of PSP are very similar to Parkinson's. In fact, if you are not a trained clinician, you would be hard-pressed to tell them apart at the early stage. However, there are a few distinct differences in their presentation that we'll cover. What does PSP cause? Progressive supranuclear palsy does cause damage to the globus pallidus, subthalamic nucleus, and the substantia nigra. The damage to the substantia nigra explains why this condition can manifest signs and symptoms that mimic Parkinson's. However, in this lecture, we're going to focus on PSP's damage to the oculomotor nuclei in the brainstem. It is the damage to the cranial nerve 3 nuclei that clearly distinguishes this condition from all other basal ganglia conditions. PSP is categorized as a tauopathy, meaning that this condition is linked to an abnormal amount of tau proteins. In fact, the histological hallmark for PSP is the presence of tau protein-including bodies in the neurons of the affected tissues. We will cover other tauopathies in this course: Alzheimer's and Pick disease, which is a type of frontal-lobar degeneration. You may want to start a list of commonalities of conditions because the boards are fond of asking questions like, which group of conditions are considered a tauopathy, or something like that. The loss of vertical gaze is a key unique sign symptom of progressive supranuclear palsy. The loss is a result of damage to the oculomotor nuclei in the brainstem. Looking at the eye movement diagram, you can see that a PSP patient will have a very limited movement of their eyes, and the condition is typically bilateral. Signs and symptoms of PSP. As you can imagine, a person with supranuclear palsy's damage to the 3 basal ganglia and the oculomotor nuclei would have serious problems with walking, balance, and eye movements. Some of the signs and symptoms that PSP patients have that are similar to Parkinson's disease are muscle rigidity, bradykinesia, loss of balance, unsteady gait, dementia in the late stages, and dysphagia. Signs and symptoms that are very different from Parkinson's disease are vision problems due to loss of vertical gaze, neck extension due to nuchal dystonia, and PSP patients do not have any tremors. What is Huntington's disease? Are you familiar with the song The House of the Rising Sun? I have a YouTube link to it in the Huntington folder inside the video folder in the learning materials. It's a really good song. I'm mentioning the song because it was adapted by a fairly well-known singer-songwriter, Woody Guthrie, the guy in the photo. Woody took the lyrics from an old miner song from the 1900s. He changed the lyrics a little, wrote a new melody, and recorded it. Woody Guthrie died from Huntington's disease in 1967. Prior to his death, there was little known about this disease and no research at all. 1 month before Woody died, his wife Marjorie started a small support group to spread information about this condition. She started by reaching out to people all over the United States who had family members with this condition. Then she went worldwide, forming the Committee to Combat Huntington's Disease, which eventually became the Huntington's Disease Society of America. Since then, the Society researchers in 1983 identified the first genetic marker for this condition and is diligently working on a treatment for a cure. Unfortunately, 2 of Woody's daughters from his first marriage also died from this disease. Huntington's disease is an autosomal dominant genetic disorder. It causes severe, terminal neurological degeneration. It is characterized by progressive movement disorders, most specifically chorea. In fact, the disease used to be called Huntington's chorea. The typical age of onset is age 30 to 50 years old. Prior to education about this condition, many people who had Huntington's but did not know it would self-medicate with alcohol, which actually did suppress the abnormal movements for a little while. The late onset and lack of understanding genetics is probably the main reason this condition perpetuated. As mentioned previously, this condition is relentlessly progressive and typically fatal within 15 years of onset. Abnormal coding. The genetic abnormality associated with Huntington's disease is that it codes for too many CAG repeats during synthesis of huntingtin. Normal huntingtin genes contain 6 to 35 repeats. Abnormalities occur in the protein when there are more than 35 repeats, thus Huntington's disease. The number of CAG repeats in a sequence determines the age of onset of Huntington's disease. The more CAG repeats there are in a strand, the earlier the onset. How does the abnormal huntingtin affect neurons? The abnormal huntingtin protein causes premature cell death known as apoptosis. Neurons aren't supposed to self-destruct. The normal huntingtin protein gene inhibits apoptosis, saving the neuron. The inability of neurons to prevent premature cell death causes profound loss of striatal neurons that starts with the caudate nucleus and progresses to the cerebral cortex. Huntington's movements and gaits. Huntington's disease will manifest an abnormal choreiform gait and chorea body part movements. Sometimes the chorea combines with athetosis and it's known as chorea athetosis. We covered this last week. Chorea involves involuntary jerking movements and chorea athetosis combines the jerking movements with writhing of hands. Individuals with Huntington's disease may also develop bradykinesia and muscle rigidity. Bradykinesia and muscle rigidity are 2 of the clinical triads for Parkinson's disease. However, the hyperkinetic nature of chorea will distinguish this condition from Parkinson's. Loss of GABA. One of the theories behind the abnormal movement and gait associated with Huntington's disease is loss of GABA neurons in the caudate nucleus. GABA is the primary inhibiting neurotransmitter in the brain. If the caudate doesn't have enough GABA neurons, it cannot adequately inhibit spontaneous outbursts of globus pallidus and the substantia nigra activity. Clinical features. On this slide, I'm listing the signs and symptoms according to the progression of the disease. Typically, the first notable sign symptom is abnormal movement, such as chorea and/or choreathetosis. Second, minor cognitive disorders begin to emerge, such as forgetfulness, difficulty at organizing thoughts, and learning new information. As the disease progresses, Huntington's patients will develop psychiatric disorders. They will develop severe depression, not so much because of the emotional reality of a terminal condition, but it's due to actual brain injury. Along with depression, the patient will become irritable, angry, even violent, while at the same time apathetic. Advanced HD will lead to dementia and eventual death. It's truly a horrible disease. What is Wilson's condition? What is a hereditary digestive system disorder doing in a neuropathophysiology course? I'm glad you asked. It is here because, sadly, eventually the damage caused by toxic levels of copper eventually reach the brain. Wilson's disease is an autosomal recessive genetic disorder caused by a mutated gene. This mutated gene prevents the liver from releasing copper into the bile to ultimately leave the body. As I mentioned, if the body can't get rid of this copper, it will build up and accumulate in the liver, eyes, and brain. The liver takes the brunt of the disease, often being diagnosed as hepatitis in the early stages. Once it accumulates in the eyes, you'll see a visible copper coloring ring around the irises, as seen in the next slide. Classic sign. Kaiser-Fletcher rings are a classic ocular sign for Wilson's disease and a board question favorite. They can be difficult to see with very dark brown eyes, but an ophthalmologist can see them with a slit lamp microscopic exam. Wilson's effect on the brain. When Wilson's disease reaches the brain, it primarily affects the putamen. It causes atrophy of that basal ganglia. This atrophy can be visualized on MRI. It has been dubbed the panda sign because the atrophy looks like the face of a panda bear. Do you see it? The neurological signs and symptoms associated with Wilson's disease are movement disorders such as wing beating tremor. I have a video of this in the Wilson's folder showing what it looks like because I cannot figure out how to describe it. The other movement disorders are uncorded voluntary movements and chorea or choreathetosis. Muscular rigidity signs and symptoms present with dystonia, particularly in the hands and fingers, a mask-like face similar to Parkinson's, dysphagia, which is difficulty swallowing, and dysarthria, which is difficulty forming words typically due to brain damage. If the Wilson's patient is ambulatory, they will demonstrate a combination of the spastic diplegic scissor walk and chorea gait. Wilson's etiology. Fortunately, with the advent of genetic testing, Wilson's disease is rare, approximately 1 in 30,000, with an equal male to female preference. This condition affects the young. Symptoms can begin as early as age 5, but still can manifest up to age 35. Rarely will this condition appear after age 35. There are 4 proven lab methods available to confirm diagnosis. Number 1 is genetic tests. Then there is liver biopsy and quantification of copper serum levels. Lastly, there is the panda bear sign in the MRI, which will not show until the advanced stage of this disease, and most likely the patient would have been diagnosed before they developed the neurological symptoms.